Thank you, Chris, and thank you, David, for the kind invitation. Our previous speakers focused on muscle health and biology. I'll speak now to a specific systemic consequence of altered muscle structure and function in human heart failure, and that would be the muscle sympathetic response to acute exercise in these patients. I have been supported entirely by peer review agencies and have no other disclosures to make to the group today. Now, heart failure has been defined this year as a clinical syndrome with symptoms or signs caused by a structural or functional cardiac abnormality and corroborated by elevated natriuretic peptide levels or objective evidence of pulmonary or systemic congestion. It's been classified clinically by left ventricular ejection fraction as either reduced, an ejection fraction less than 40%, or mildly reduced or preserved. The bulk of clinical and experimental research has been in patients and experimental preparations with reduced ejection fraction, and that's really going to be the focus of today's presentation. Now, why is this important? Well, heart failure in Canada is the most common reason for hospital admission in those above the age of 65. About 30% of those admitted will die within a year of their diagnosis. And even with contemporary therapies, annual mortality exceeds 5%. Now, what are some of the predictors of that mortality? Well, one predictor that I've been studying for almost 4 decades has been autonomic disequilibrium. Whether it's a measure of vagal tone or a measure of sympathetic drive, in a loss of vagal control of heart rate, or an increase in sympathetic drive to the heart, the kidney, or to the peripheral vasculature, each of these measures has been shown in longitudinal studies to predict premature death. In heart failure with reduced ejection fraction, reduced exercise capacity also predicts survival. That was true 20 years ago before contemporary medical therapy and device therapy, and it's true at the present day as well. So these two concepts are ones that I would like to merge together in this presentation. Well, if heart failure is really a structural problem, why focus on the autonomic nervous system? Well, autonomic disturbances are intrinsic to heart failure. They're seen right from the very start of heart failure. Basal or stimulated sympathetic nerve firing or norepinephrine release often exceeds homeostatic need, so that a reflex response that's initially adaptive will become maladaptive. And it's that maladaptation that predicts symptoms and predicts prognosis. These autonomic disturbances are not addressed fully by current evidence-based drug or device therapy. And hence a major theme of our laboratory has been to elucidate and find means of targeting safely a specific maladaptive mechanism that has the potential to improve morbidity and mortality. And over the last 30 years, we've developed this construct where we've shown that a principal adaptive mechanism is the arterial baroreceptor, an inhibitory input to the central nervous system. When blood pressure falls due to a drop in stroke volume or pulse pressure falls, this leads to loss of inhibition of sympathetic outflow, and you see a marked increase in sympathetic drive to the heart, the kidney, the adrenal gland, and to peripheral vasculature. But there are maladaptive reflexes as well. These include the chemoreflexes. We have discovered an atrial reflex that's stimulated by high filling pressures that leads to increase in sympathetic drive to the heart and to the peripheral vasculature. Renal afferents are also sympathoexcitatory, and muscle metaboreceptors have been shown to exert a very prominent role in patients, particularly during exercise. Now, Jerry Mitchell prepared this nice illustration of the exercise pressor reflex, which highlights these two reflexes arising from exercise muscle. One is the mechanoreflex. There are mechanically sensitive receptors that the afferents are prominently group 3 fibers, and there are metabolically sensitive receptors, and those afferents are predominantly group 4 fibers. The input to the central nervous system results in an increase in blood pressure, heart rate, and left ventricular contractility mediated through the sympathetic nervous system. Well, the reason for our interest in this in heart failure is the concept that exercise intolerance and fatigue may be due to increased sensitivity of these group 3 and group 4 muscle afferents. The paradigm that has been developed, and particularly in this review article by Andrews and Crisafulli, is that in chronic heart failure, there's reduced cardiac output and skeletal muscle perfusion during exercise. This leads to a myopathy, a reduction in muscle mass, alterations in muscle metabolism, and sensitization of these muscle afferents, resulting in an exaggerated exercise pressor reflex. Now, the initial approach to that was to look at peripheral resistance or blood pressure. But with our microneurographic approach, we elected instead to look at the stimulus of exercise and the response through direct recordings of efferent sympathetic outflow to the calf vasculature. Now, how do we do that? We do this using a technique called microneurography that was developed in Uppsala in the 1970s. And I happened to go there as a volunteer when I was doing my PhD and had my own fibular nerve impaled. I brought the technique to Canada in 1985, and we've been studying sympathetic recordings in patients with heart failure, hypertension, and other cardiovascular disorders. In essence, there's a tungsten active electrode that's inserted into the fibular nerve. The idea is to place it into a fascicle where one can record efferent muscle sympathetic bursts. There's a ground electrode. The signals are amplified 50 to 70,000 times, and you get these pulse synchronous bursts of sympathetic discharge that can be inhibited or excited by conventional maneuvers. Importantly, the norepinephrine release at the nerve terminal is proportional to the frequency and amplitude of these bursts. The measurement is generally in terms of burst frequency. And you can see that with the increased firing, you have norepinephrine release, vasoconstriction, and an increase in total peripheral resistance. So this overcomes the problems with an indirect measure such as blood pressure, and we can look directly at the neural response to the stimulation of these afferents by exercise. Now, our heart failure research has been led by Kathy Notarius, and she set up this paradigm where we had volunteers with heart failure in the dark blue and healthy age-matched control and sex-matched controls here in the light blue, performing randomly 4 sets of exercise, and each conformed to the same protocol: a baseline, 1 minute of hand grip, a second minute of hand grip, and then a cuff is inflated at the upper arm, exercise ends, and ischemic metabolites are trapped in the forearm in order to stimulate the metaboreflex. And this would be the post-hand grip ischemia, and then recovery. And you can see that there are 3 isotonic exercise and 1 isometric exercise. First, I'd like to point out that the sympathetic traffic at rest in the individuals with heart failure is approximately 60% higher than the sympathetic traffic in the healthy control subjects at baseline. I'd like to point out that during isotonic exercise, when there is virtually no sympathetic activation in the healthy controls, there was an increase in 10% of maximum voluntary capacity with the second minute of hand grip. We saw this with 30% isotonic hand grip. At 50% of maximum voluntary capacity, even 1 minute of hand grip caused sympathetic excitation in heart failure, increased further with the second minute, and this was sustained into post-hand grip ischemia when the metaboreflex is being stimulated as well. Here you can see that if one has the heart failure patient perform isometric exercise at 30% maximum voluntary capacity, within the first minute there's an increase in sympathetic outflow. This is augmented in the second minute and sustained during selective metaboreflex stimulation during post-hand grip ischemia and sustained into recovery. So the conclusion derived from this set of experiments was that isotonic and isometric hand grip increase muscle sympathetic activity reflexively at a lower threshold in heart failure by stimulating mechano and metaboreceptor afferents. Now, what was interesting is if we just took the isometric exercise and then subdivided these patients into those who had a VO2 peak above 56% of that predicted here in the open triangles and below 56% of that predicted here in the closed triangles, Note that this was uncoupled from the ejection fraction. Numerically, those who had the better exercise capacity it's actually the lower ejection fraction than those who had the poor exercise capacity, who tended to have a higher ejection fraction. But those who had relatively preserved exercise capacity had sympathetic outflow at rest that was virtually identical to those of the healthy control subjects. But during exercise, you could see that by the second minute of hand grip, there was indeed a stimulation of the sympathetic nervous system, but through the mechanoreflex. When you had post-hand grip ischemia, the values returned to baseline. Whereas in those who had limited exercise capacity, less than 56% of that predicted, their resting nerve traffic was more than double, and there was a further increase with exercise seen at the first minute of hand grip, and then during the post-hand grip ischemia, there was a sustained elevation of sympathetic traffic. So what we found was that the muscle metaboreflex stimulation by post-hand grip ischemia was selectively present in those with a low VO2 peak and not in those with a high VO2 peak relative to controls. So the insight from this set of experiments was that in non-diabetic supine patients with heart failure, muscle mechano and metaboreflex evoke sympathetic responses to hand grip are a function of exercise capacity rather than ejection fraction. And also it was informative because one really couldn't predict the level of sympathetic activity during exercise from the resting values. Well, what about symptoms? The cardinal manifestations of heart failure are shortness of breath and fatigue, which may limit exercise tolerance. When you see this type of association, and when you see the predictive values of both autonomic disequilibrium and low exercise capacity, we began to wonder whether there was a neurogenic constraint on exercise capacity. And that really was not mainstream thinking at the time that we began this research. But if one goes back to the initial paradigm, it would seem logical if there is an exaggerated exercise pressor reflex, this should lead to exaggerated vasoconstriction during effort, and this could lead to early fatigue and reduced exercise tolerance. Also, increased perceived exertion could lead to that sense of fatigue and limit exercise capacity. We had some interesting data at rest suggesting that there was a peripheral rather than a central neurogenic limit to exercise. Here we have sympathetic firing frequency on the left and cardiac norepinephrine spillover on the right. And it was only the sympathetic nerve traffic and only in the heart failure patients where we saw an inverse relationship between sympathetic excitation and predicted VO2 peak. This was not seen for cardiac norepinephrine spillover, which we used the radio tracer technique in our research cath lab just down the hall here from where I'm sitting. What Kathy did was she set up the one-leg cycling method, and she was the first really to be able to do this successfully in patients with heart failure and in age-matched control subjects. And when you think of it, people don't get fatigued during daily life. They don't get short of breath during hand grip, but they do get short of breath. They get fatigued. They stop leg exercise. They stop dynamic exercise. Though this we felt was the more important set of experiments. The hypothesis Kathy was testing was that the contralateral sympathetic response to mild to moderate one-leg exercise is augmented in heart failure relative to age and sex-matched controls. And the protocol involved 2 minutes of pre-exercise baseline, 2 minutes of no-load cycling, and 2 minutes of cycling at 50% of the peak VO2 measured on a previous day. And in healthy middle-aged individuals, just as has been shown earlier in healthy young individuals, there is actually sympathetic withdrawal during exercise. And that would be logical. That would lead to greater blood flow to the leg. In heart failure, however, we saw paradoxical sympathetic excitation. Here you can see this one individual with no load cycling and with 50% of VO2 peak. You saw a progressive increase in sympathetic traffic to skeletal muscle. In the group as a whole, we had 16 heart failure patients, 4 women, controls, 13 patients, 3 women. The peak VO2 was about double that in the controls than in the heart failure patients, whose ejection fraction was quite low at 31%. Here you see on the left the 2 minutes of zero load cycling, and on the right, 2 minutes of 50% peak VO2. The open bars are the controls, the closed bars are the heart failure, changes in heart rate with exercise above, changes in sympathetic burst frequency below. And here you can see the group mean values, a sympathetic withdrawal with both levels of exercise in the controls, paradoxical sympathetic excitation in the heart failure group. What about the relationship that we proposed? Well, if one looked at the population as a whole, here you have sympathetic burst frequency on the abscissa, and you have predicted peak VO2 in the ordinate, and you can see an inverse relationship such that 41% of the variance in VO2 peak could be predicted by the burst frequency at peak exercise in this formulation. However, this is an admixture of controls and heart failure patients, and it's looking at absolute values. Daniel Kerr has gone on to extend these experiments, looking at the change in burst frequency from baseline versus peak VO2, and he's done this in heart failure here on the left and in control individuals on the right. And here you can see that the response is there. It's an inverse relationship, and it's specific to heart failure. We're not seeing this in our healthy control individuals. We had intended to show flow data, but COVID has interrupted that. But the data that I'm showing here from Utah corroborates our hypothesis. Here, the alpha adrenoceptor antagonist is phentolamine is infused during leg exercise in control subjects on the left and in heart failure on the right. And the data here are shown at rest, at 0 watt workload, at 5 watt workload, and at 10 watt workload. And here's leg blood flow and leg vascular conductance. And the key point is if one looks at the heart failure patients at rest and at every level of exercise, you can see that there's an attenuation of the leg blood flow response, as would be predicted by our paradoxical sympathetic excitation. When you block the activity of the sympathetic nervous system by phentolamine, you increase leg blood flow at all levels of exercise, and you increase leg vascular conductance at all levels of exercise. So this is consistent with the concept of a neurogenic constraint. Can we reverse this? Well, the logical approach, since there's no pharmacological approach at this time, is to use physical training as an intervention in order to determine what the impact would be on sympathetic outflow at rest and during exercise. And we've had 18 patients go through a training protocol with Paul O's supervision at the Toronto Rehab Institute. And overall, you can see that in these 18 individuals, there's an increase in VO2 peak of about 3 ml per kilograms per minute, and a corresponding decrease in sympathetic nerve traffic to skeletal muscle vasculature at rest. Well, what happens during exercise? These are the novel data, as the resting data had been shown by our colleagues in Sao Paulo. What Kathy showed was that with the mild cycling protocol at no load, there was indeed sympathetic inhibition. And you can see this at 1 and at 2 minutes of no load exercise. However, with the moderate cycling exertion, we don't see any inhibition. The sympathetic burst frequency during exercise is similar to that in the trained state, in the untrained state here. And here's the drop that you see in the control individuals that I alluded to earlier. The metabolite reflex also is impacted by this training protocol. Here you can see the post-handgrip ischemia data in the heart failure patients pre-training and in the heart failure patients post-training, where there's a drop in the reflex sympathetic excitation elicited when the muscle metabolite reflexes are stimulated by post-handgrip ischemia. And here are the data in the control participants. Now, what was really concerned to us is that the training effects that we saw on the autonomic nervous system were really confined to those individuals who started off the rehab program with a relatively preserved exercise capacity. And these are the 11 individuals on the left. You can see it is those individuals that exhibited sympathetic inhibition during exercise and a further drop during recovery. All of these individuals were beta blocked. We did not see any heart rate effect of training, but interestingly, the heart rate appeared to be higher after training in those with low VO2 peak, and there was no impact on sympathetic outflow. So to summarize this body of research at this point, I would say that we've shown that sympathetic activity increases reflexively at a lower intensity threshold during handgrip exercise in heart failure patients with reduced ejection fraction compared with healthy controls, due partially to greater muscle metaboreflex activation. And this response is exaggerated in those with the lowest exercise capacity. In healthy middle age, sympathetic activity falls during mild and moderate cycling, but increases paradoxically in patients with heart failure and reduced ejection fraction. Exercise capacity in heart failure with reduced ejection fraction relates inversely to sympathetic outflow at rest and during exercise, in contrast to controls consistent with a neurogenic limit to exercise. Training patients with heart failure blunts the sympathetic increase during mild exercise and metaboreflex stimulation by post-handgrip ischemia, and those with relatively preserved exercise capacity exhibit the greatest sympathoinhibitory training effect. Now, when David extended the invitation, I thought that we would be able to provide more data, but our lab is in the middle of the clinical teaching unit that was converted into a COVID ward at the Toronto General Hospital, and we've been shut basically for the better part of the last 9 months. And so I'd wanted to speak to the mechanism for this sympathoexcitation, whether it's due to the mechano-metaboreflexes or augmented chemoreflex sensitivity, or the atrial reflex that we discovered that I alluded to earlier. I would have liked to have addressed the question of whether one or more of such specific reflexes are influenced by training. And we're moving our work as well now into the patients with heart failure and preserved ejection fraction. These individuals comprise about 50% of the contemporary heart failure population in Canada, particularly amongst the elderly and particularly amongst elderly women. And the protocol that we're performing in order to do this is the 8-minute protocol I described earlier with rest, unloaded cycling, and moderate cycling. But 3 interventions are being randomized, and those are seated cycling with post-exercise thigh ischemia, where there's a cuff inflated over the thigh in order to look at the metaboreflex, supine cycling in order to shift blood to the atria, and seated cycling with 32% supplemental oxygen in order to suppress the chemoreflex, the peripheral chemoreflex. Now, what we've shown, and this is data from our lab over several decades in 176 individuals, is that there's absolutely no relationship between ejection fraction and sympathetic firing, indicating that these maladaptive reflexes have really turned on and are raising sympathetic outflow above and beyond that what one would predict would be the case simply on the basis of a drop in cardiac output or a drop in stroke volume. And what is evident is that patients with heart failure and preserved ejection fraction also have sympathetic excitation. We have data from 4 before we were obliged to stop our experiments because of COVID, but we would like to extend our paradigm of exercise and exercise training to this particular population. So I'd like to leave with the following messages. The findings I presented are consistent with the emergence in heart failure of maladaptive reflex sympathetic excitation at rest due to sensitization or stimulation of group 3 or 4 afferents in skeletal muscle and lead to a peripheral neurogenic constraint on exercise capacity. In these patients with heart failure, reduced ejection fraction, and relatively preserved exercise capacity, muscle sympathetic activation can be ameliorated at rest and at low workload by conventional cardiopulmonary rehabilitation. Future research should strive to identify strategies to extend the benefits of conventional exercise training to those most limited, because those are the individuals that need exercise training the most. And with that, I'll conclude. Thank you very much for the opportunity to present this work. These are part of our group, Daniel Keir, Kathy Notarius, Bev Morris were responsible for most of the exercise work that I presented, and here's the chair in our lab for the one-legged exercise. And I'd be up fishing today at our annual member guest day were it not for David's invitation. Thank you very much.
Thank you very much, Dr. Floras, and that was exactly precise timing. So that's wonderful talk. And we already have 2 questions from Peter back, so I'll ask each one separately so you can answer one at a time. The first question is, and first of all, he says, welcome to York, and thanks for, as usual, a great informative talk. First question, are there changes in anticipatory aspects of the neural control, either on the cardiovascular centers or directly on the peripheral cardiovascular system?
By anticipating control, are you referring to central command, Peter? I imagine that's what you're describing. We eliminate the concept of central command by inflating the cuff. So exercise ends, the volition ends at that particular point in time. We haven't done an experiment to see what happens if you try to get a central command out of the actual physical exercise, but the reason that we did the one-leg exercise experiments was to try to replicate what's happening in our patients during day-to-day activity. And so I think our paradoxical excitation is the sum of all of these potential inputs.
Okay. And Peter did say yes, but anyway, the second question. He understands that your talk was not able to directly address the atrial heart reflexes, but do atrial reflexes on heart rate differ between normal and heart disease patients? Heart failure with preserved ejection fraction, or HFEF? If so, how? We have some data in a mouse aortic regurgitation model that I would like to share with you to get your input if you're willing and interested.
Well, when we did our work on the atrial reflexes, what we were doing was we were doing non-hypertensive lower body positive pressure and look at the impact of shifting blood to the legs up to the atria selectively. And in those experiments, which were published in Circulation in 2015, there was no impact on heart rate.
Okay. I have a quick question. To what degree, what do you think is the ultimate mechanism for this peripheral adaptation to heart failure? Could it be related to systemic inflammation that might be elevated in these patients, or some other global factor? Or is it some of these new theories about heart muscle crosstalk that is probably not very well defined yet?
Or all of the above? No, that's one step ahead of us. What we're looking at is the systemic adaptation or maladaptation.
Right. Oh, sorry. Heather Edgell does have a talk. I missed it. Or a question. Thank you for your talk. Do you think that a secondary activation of the sensitized chemoreflex in heart failure could play a role in the increased SNA response during metaboreflex activation?
Absolutely. And in fact, these are data that I'd hope to share with you. We've brought Jim Duffin into the lab, and we've developed his rebreathing method, and that has allowed us to look for the very first time at the specific synchronous ventilatory and sympathetic response to isolated peripheral and chemoreflex stimulation. And we're in the midst of doing those experiments in heart failure. There's work in normal individuals by Strickland and his colleagues showing that the peripheral chemoreflex is involved. And we've done some experiments with 100% oxygen, but I don't have the complete data to share that with you. But I suspect that several of these factors are happening. Curiously, and we don't understand why, but even at rest, only about half patients with heart failure demonstrate excitation or sensitization of the peripheral chemoreflex. And these are the individuals that have been shown to die prematurely compared to those without chemoreflex sensitization. One of the breakdown products of exercise, adenosine, we've shown stimulates the peripheral chemoreflex. We've shown that we can block sympathetic activation with 100% oxygen in that context. So there are a lot of communications occurring between exercising muscle and the chemoreflex.
Thank you very much for all of your responses and for your really wonderful presentation today, Dr. Floras.
It was a pleasure. Thank you.